I have to say it's a real pleasure to be here. I've given the Tuesday lecture before, but that was when I was a visiting surgeon, so it's particularly a pleasure for me to be here as a permanent member of staff. And I'd just like to thank you all for your warm welcome over the last 3 to 4 months. It's been a fantastic start, and I'm really happy to be here. So I'm going to be talking about Aspetar precision surgery. I do have some disclosures. Some of the work I'm going to be talking about has been from peer-reviewed funding. And whilst I won't be going into in depths of any sort of the industry collaborations that we've had, there's some of the work may allude to some of that. In terms of an overview, what I really wanted to do is introduce the concept of Aspetar precision surgery and then really use ACL reconstruction as an example of how that fits into what we're going to be doing in the coming years. I'm going to go off on a little bit of a tangent then with a bit of a journey into patient-reported outcomes in ACL reconstruction. And this is really more of an introduction of concepts and a teaser for what may come over the next 5 years. So hopefully we'll all get something from this. So what is Aspetar precision surgery? Well, ultimately, we want to be in a position where we're taking an injured athlete and getting them back to play, but not only play, but also performance. And with that, we have an extremely expert group of clinicians, both on both the surgery and the sport medicine side, imaging, anesthesia. We have a huge number of really key individuals here that are involved. Obviously, with the imaging side of things, patients may end up in the OR. And then rehabilitation is an absolute key as a critical component of what we're trying to do. And then you put those all together and put it under one roof, and you have a fantastic house, really underpinned and really held up by all the other specialties in and around us in terms of the nursing staff, the administrative staff, the research staff. And it really is a very unique centre that provides us to be able to do what we do for our athlete population. And so what are we looking at in terms of a mission and values with Aspetar precision surgery? Well, it's innovative care, surgical solutions. We're looking for evidence-based, cutting-edge techniques and development of those, and utilising those in our practice. You're going to hear me say individualized an awful lot. Gone are the days, particularly in ACL surgery, but the majority of surgeries that we do where we focus on just one size fits all. It's not that anymore. It's individualized approach to diagnosis, treatment and rehabilitation. And we're looking not only about a return to sport, but an optimized return to sport and function. So really getting back to performance levels. So what was this as individualized approach? Well, it could be upper limb surgery. We can be using precision tools to develop our best possible outcomes in terms of our surgical techniques. New techniques in ankle surgery, ankle stabilization. We could be looking at regenerative options in terms of looking at rotator cuff repair. Orthobiologics, you're going to see an awful lot of that over the next 24 months, where we're going to see this new orthobiologics lab and bringing in some of the stem cell research that has been utilized and bringing that into our practices. And of course then the use of technology, just looking at planning of surgery from smartphone base, bringing it through into the application in the operating room. So I'm going to use ACL injury as a way to illustrate how this can work for us here at Aspetar, but also further afield. And if you look at ACL injury, most of you are very well aware, this is the bread and butter of what we do at Aspetar. But, there's 200 to 250,000 ACL injuries per year in North America alone. The incidence is increasing, particularly in female athletes. So it's a significant problem. And when we think about an individualized treatment of ACL injury, I hate these conversations where we're constantly talking about should you do non-operative versus operative. Well, they all work, and they all work for individual patients. You talk to your individual patient, and rehabilitation for some patients may definitely be the best option. And if you look at the Oslo, Delaware cohort, clearly having a period of neuromuscular rehab, whether that's prior to surgery or not having surgery, patients do better with that rehabilitation process first. We can look at randomized clinical trials of reconstruction either at an early stage or as a delayed fashion. And this study showed that there was no difference if patients had a delayed surgery or non-operative treatment. And I think it's a very useful tool to be able to counsel patients to say, you don't need to have an operation. You can try neuromuscular rehabilitation. If you do well and you're doing fine, you don't necessarily need an operation. If you struggle later on, we can do the ACL surgery later. Interestingly, with these two things, there's really no difference in patient-reported outcomes when you compare surgery to non-surgery. What about cross bracing? This is something that we're seeing an awful lot more. This is an intervention, a non-operative intervention, and we're getting a lot of conversation from this, particularly from Australia, and it's starting to creep across the rest of the world. I'm sure many of you have had patients asking about this, and I think, it is of interest. But again, it comes down to an individualized approach. There's no question that some patients will do well with this type of protocol. Equally, a lot of patients do very well with absolutely no treatment at all, with just neuromuscular rehabilitation. There's some issues with this type of treatment. It's this case series that was published. The primary outcome was looking at MRI scores and really not focusing on laxity. What's important here, though, is that there's a 14% failure rate. It's very, very difficult to predict who's going to do well. And when we're talking about our athlete population, that is a challenging piece. That is a challenging argument to be able to say, well, we could give this a go. You're going to have a period of time locked in a brace at 90 degrees, but then maybe, and you've got a 15% chance of failure. So the question, we really need to get better at predicting outcome. What about ACL repair? Okay, well, that's something, again, that's becoming very popular over the last 5 years. Systematic review on the left-hand side really shows that if you compare it to ACL reconstruction, there's a 63% reduction in failure with ACL reconstruction. So failure is a problem when doing ACL repairs. In the older patient population, actually many of them do very well with no treatment at all. Again, the possibility of an ACL to heal itself is there. Okay, yes, if you treat them in ACL repair, well, it's a no-brainer that many of those older patients will do quite well. If you take the younger patient population, it's potentially a disaster in terms of failure rates. But there's no difference in patient-reported outcome scores. And I'm going to say that a lot. If you look at bridge-enhanced ACL repair, okay, it's a biological augmentation of ACL repair. This was a randomized clinical trial comparing the Bear technique to ACL reconstruction with a hamstring tendon autograft. No difference in subjective IKDC scores, but failure rates 14% with the repair, 6% with ACL reconstruction. So again, individualized approach. What is important to the individual patient? So this brings me to ACL reconstruction. So what are we trying to do? Well, we want to restore translational and rotational stability. We want to replace the ACL with a graft, and of course we could have a conversation all on its own just about graft choice, but I'm not going to do that today. It's a significant cost burden both to the patient but also the societal burden. And unfortunately, no matter what we do, whether it's non-operative or operative treatment, the initial injury sets off an inflammatory cascade. And unfortunately, the risk of osteoarthritis later down the line is high. And that's particularly problematic if you lose a meniscus, 50% at 10 years. So what are the important ACL outcomes or ACL reconstruction outcomes to me, to our patients? Well, let's talk about failure rates. If you look at the overall all comers, if you take patients that most systematic reviews, mean age of patients usually sits between 27 to 29. Overall rates round about 2%, and it really depends on the study that you look at. As soon as you start drilling down into the younger age population, we see this increase in failure rate, anything from 5 to 25% depending on the series that's been reported. So now we're getting into this high-risk individuals. If you look at a contralateral ACL along with that, it's even worse. 20 to 30% of the time you may end up with another ACL injury. Now, whether it's the same ACL or a contralateral injury, for a patient, for an athlete, that's a disaster. That's basically, they've missed the first season because of their ACL injury, they've done the rehab, they go back to the second season, and then they have another ACL injury. That's 2 to 3 seasons out, and for a high-level athlete, that could potentially be the end of their career. And this has been shown in multiple studies, and the Moon cohort has really been very illustrative of looking at patients when they actually then drill down into that younger age population. And again, it really just reiterates this high prevalence of contralateral and ipsilateral ACL injury in these young athletes. And that's where we really have to think about, you can't just take all comers, you have to be more specific at what you're dealing with. And that's why when we designed the Stability 1 trial, we really focused on the younger patient population. These are the patients at risk of re-injury, and we want to do something surgically to try and reduce the risk of re-injury. And that's why we really selected out patients under the age of 25 and then looked at key characteristics that put them at high risk of re-injury. Now, interestingly, a colleague of mine, Christian Fink in Austria, shared with me a score that they've been using over the last number of years to really highlight their at-risk patients, and it's a composite score based on a number of different factors, and based on that score, they'll then decide whether or not they would add a lateral tenodesis to their ACL surgery. Interestingly, when I looked at the score, all of our patients in Stability 1 actually then qualified to have an LET. So that just really tells you that our criteria shows that our patient population is really at high risk. So what was the study? Well, it was intervention of standardized ACL reconstruction. We were using a hamstring tendon graft at the time. This was the most popular graft, certainly in Canada. And then we compared that with or without the addition of a lateral tenodesis. And many of you will have seen LETs. It's a very commonly used procedure here, particularly over the last 5 years. And essentially it's a strip of the IT band that's reattached to the lateral femoral condyle, and it really tries to prevent ACL failure and improve rotational stability. I don't want to go too much on about Stability 1, but really it's a reduction in rotational laxity. We see a 40% reduction in rotational laxity. The important statistic was that we saw a 66% reduction in graft failure. So this was really significant and had a big impact on how we treat ACLs around the world. There's no increase in overall complications, and we didn't see any difference in strength or functional testing at 12 or 24 months. Now, if we look at our predictors of outcome, and this is where we're really getting into now. We know that LET works. We know that it's functional. The question is, do we need to do it on every single patient, or can we try and be more selective? Just like when we see that patient talking about non-operative versus operative, cross-bracing versus neuromuscular training, ACL repair, we need to try and be more specific about what we're doing. Again, decision-making. We need better decision-making tools. So when we look at our predictors with this particular study, we can see that the addition of an LET to a hamstring autograft reduces the odds of graft rupture by 60%. Now that's been shown in multiple studies. Now we did a systematic review that showed across the board with a soft tissue graft that you get a reduction of approximately 50% of failure rate. That's significant. Okay, that's a big deal. And we've just recently convened a further consensus statement. It was a meeting that we had in Naples, Florida, just in November of last year. And the number one point that we brought up from that consensus is that if you're treating a young athlete who's going back to sport, ACL reconstruction, and if you choose to use a hamstring tendon autograft, then you should be adding a lateral tenodesis. And the data really is very strong in terms of supporting that. What about age? Well, we know that age has every increase in 1 year increase in age reduces the odds of rotational laxity. Now we can see from multiple studies, I've already talked about Moon, but age has really shown as probably an indication of activity level. And here you can see with the Moon cohort that Mark's activity score was highly correlated with younger age. And so again, that's something that we can really think about when we're seeing patients in clinic. What about return to sport time? Well, if each month that a return to sport time is delayed, reduces the odds of graft rupture by about 14%. Now, this editorial from Tim Hewitt, suggested maybe we should be delaying return to sport until up to 2 years. Well, obviously that's not practical, particularly for our athlete population. But we can use return to sport testing, and obviously that's been shown to be very helpful in terms of what we do here at Aspetar in terms of reducing the risk of re-injury. But equally, just a delay. This is a randomized study from Julian Feller and Kate Webster in Melbourne. That maybe just delaying isn't all that the purely just the biological response of delaying is not really what we're looking for, because there's no difference between these two groups, and that really functional testing is much more important. Preoperative high-grade knee laxity. These are things that we can do in clinic. Okay, we can examine the knee. We can see whether or not a patient has got high-grade laxity, whether that's generalized ligamentous laxity, knee hyperextension recurvatum. And if we see that we have high-grade laxity, you're 3.2 times higher odds of re-rupture. So we can choose what we can do. So again, Moon showed this, Stability's shown this. Okay, and generalized ligamentous laxity. What the thing that was really driving what we saw in the Stability trial was the presence of knee hyperextension. And I'm sure you recognize in this part of the world, we see lots and lots of patients with knee hyperextension, much more than maybe in parts of Europe. So again, this is a major issue that we have in the Middle East. Hyperextension recurvatum has been very clearly shown to be associated with high risks of failure, and even anything greater than 6.5 degrees. I'm not sure how you accurately measure 6.5 degrees of knee hyperextension. There's some significant measurement error there, but you should be thinking about that if you see that, maybe we should be doing something different. And we can look at posterior tibial slope. Again, the Arabic knee, we have significant issues with posterior tibial slope, with each 1 degree in posterior tibial slope increasing the odds of graft rupture by 15%. And if we look at age along with tibial slope, you see around about between 9 to 10 degrees, that's when we start to run into problems. And I'm not sure this projects very well, but this is a patient that I saw just in clinic on Sunday. Failed ACL reconstruction, posterior tibial slope of about 17 degrees. Just look how much anterior tibial translation there is. There's no graft that's going to be able to control that. This is a significant problem that we have. So, preoperative assessment and individualized approach. Age, activity level. High-grade laxity, hyperextension recurvatum, we can see. We can do this in the clinic very easily, very, very straightforward with good clinical examination. Appropriate imaging, radiographs. We can look at measure tibial slope. We can get notch morphology. We can use all of these to determine our risk of re-injury. And then we can take more advanced imaging, such as MRI scan. We can look at meniscus status, concomitant injuries, to determine whether or not there's anything else going on that may put patients at a higher risk of re-injury. The big question then is, well, what do we do about it? And unfortunately, it's a little bit blunt in terms of what we're able to do, because ultimately, when it comes to surgery, we can choose different grafts, and we can decide whether or not we add a lateral procedure, a lateral extra-articular procedure. Now, there are some machine learning outcome prediction tools, and you're going to see more and more of this. Everyone wants to talk about artificial intelligence, machine learning, but it requires big data. And there's some big data sets out there. There's a lot of registry studies. Sometimes the information that we get from registry studies isn't really granular enough, but certainly some of these tools have been developed. This is one that came from the Norwegian Ligament Registry. Now, we did actually a external validation of this particular tool with our stability data set, and we found in our data set that it wasn't that predictive. So whilst we can develop a prediction tool from one data set, it may not necessarily work in a different part of the world. So again, we have to be thinking about geographical variation as well. The Moon Risk Calculator, I've talked about the Multi-Center Orthopedic Outcome Network already. This is the North American series. They developed this really nice online tool, and they've really been pushing it more towards patients, because it's a really nice tool for patients to be able to use to understand that maybe not one particular size fits all. And you can plug in some information really regarding their age, their sex, the type of sport that they do, and the activity level. And really, it's a measure of their Mark's activity score. And once you put all of that information into the tool, and this is freely available online, you can then press a little button, and it's going to give that individual patient a risk, okay, of if they have normal knee laxity, a risk if they use BTB versus hamstring, or if they have high-grade knee laxity, BTB versus hamstring. So it's a very nice tool to be able to help counsel your patients as to why we should maybe be thinking about different options. The problem is it doesn't really include lateral tenodesis or quadricep tendon, and the quadricep tendon graft is becoming more and more popular. And of course, lateral tenodesis is getting very, very popular. Now, we tried to do a more of an indirect comparison. We used the Moon Risk Calculator with the Stability 1 data set, and we found that effectively that the hamstring tendon plus LET seem to be somewhat comparable to a patella tendon alone in a young age population. Now, you could argue that maybe the addition of the LET could even improve things a little bit more with the addition of an LET to a BTB, but of course we don't know that for sure. And some of this work was really impetus for Stability 2. So Stability 2 is a randomized clinical trial that is nearing completion. So I actually wrote this grant in 2018. We randomized our first patient on my birthday in 2020 in the middle of the pandemic, and now we've got 1,189 patients randomized. We should complete randomization by the end of February. So it's a huge study. In 2 years' time, we should have a massive data set. And when we can combine Stability 1 and Stability 2, now we'll have 3 grafts, all with or without tenodesis, in patients under the age of 25, and we should have a much better idea in terms of a risk predictor tool that can really try and be a little bit more specific about what we do for individual patients. Until then, you're still stuck with Stability 1 and then Consensus, and the Consensus that's going to be coming out soon will help I hope will help give clinicians a bit of an idea as to what we as the group that developed the Consensus think in terms of an expertise based. What I do, I use the lateral tenodesis in almost 100% of revisions, and then in the primary scenario, any patient that wants to go back to sport with a hamstring tendon autograft. So that's a young patient, they get a lateral tenodesis, and then high-risk individuals with high-grade laxity, and then all of these other risk factors. And the reality is, when we look at our patient population, particularly here in Doha and the surrounding area in the GCC, so many of our patients fit so many of these characteristics, hence why you see so many lateral tenodesis being performed here at Aspetar. But we can also do other things in terms of our surgical technique. And tunnel position, you won't go to an ACL meeting without someone talking about tunnel position. It gets a bit tedious. We've been talking about it for years. But the reason is because we haven't really perfected the art. That's the reality. Okay, and if you look at this study, I think it's kind of sobering in that this is a study that the members of the ACL study group we did this particular study at one of our meetings in South Africa, in Cape Town. And what the authors did is they set up a fluoroscopic image of cadaveric knees. And what we were asked to do as individuals was to, on the image, mark where we would want to put our ACL reconstruction tunnel. So this is a depiction of what the ACL study group members, where they want to put their ACL tunnel. Okay, you can see that we're all not in the same place. Okay, this is what they actually did. Okay, so that's what they wanted to do. This is what we actually did. Okay, this is the great and good of ACL reconstruction surgery around the world. Okay, significant difference between intended and actual position, significant difference between techniques. Depending on how you actually look at the tunnel, whether or not you've got your camera in the medial portal versus the lateral portal, and for those of you who don't do surgery, it doesn't really matter. Effectively, what you're seeing here is that there are differences in how we actually do surgery make a difference in how we actually effectively put our tunnels. What about the different techniques that you can use? So top line, intended position. The intended positions are all fairly similar, okay? But look at the spread down below. And this is what happens, okay? So the one on the left-hand side, this is those of us that are like Jedi Masters. We just use the Force, okay? We call this Yoda. We just know where the tunnel goes all over the place, right? Using an offset guide, some sort of some industry supplied guide to help provide where the tunnel should go. Again, significant spread among the tunnel. Some of the tunnel positions are not even in the anatomic footprint. Okay, hopefully that wasn't mine. I can tell you it wasn't. Anyway, we can use a ruler. We can measure. Okay, so we can use this very simple devices and just measure. And once we start using measurement devices, we start to get a little bit tighter. And then if we use fluoroscopy, okay, we get much, much tighter. Okay, so actually if we use something to help guide where we go, it's much better. So then you can think, why are we not doing this all of the time? Well, the reality is fluoroscopy, and you're going to be wearing lead all day, every day. Okay, it's problematic. It's got radiation. There's safety issues. It's challenging. Okay, so what are we going to be doing in the coming years? Well, we're going to be improving our accuracy. And navigation's been around for absolutely decades, but it never really took off because it's cumbersome. What you're going to see now is the advent of augmented reality, mixed reality, even robotics in surgery. This is going to happen in ACL reconstruction, no question about it. It's taken off in total knee arthroplasty, and we will see this come into ACL surgery at some point in time. So watch this space. Okay. Now, in terms of ACL diagnostics, we can also use our imaging. This is a study from Peter Verdonk, who's one of our visiting surgeons, looking at morphotypes. So looking at patients in terms of actually how their bones are shaped and the impact that has on injury and outcomes after injury, such as meniscectomy. Now, if you then take that a next step further, and of course we don't want to get rid of our radiologists. Okay, we need our radiologists. But computer AI is going to be taking over an awful lot of what we do. We can actually do things in a much more quick, in a very, very fast and reproducible manner that can give us a lot of information, again, trying to predict risk. And if we can even do things that we're now in the process of doing a study with hospital special surgery, where we can take MRI scans from patients who have had an ACL injury, and we can produce a digital twin, so essentially a model of that knee, and then we can apply loads to that knee, and they've found that depending on the morphotype, how those knees are shaped will actually predict the amount of load that goes on the ACL, whether that's tibial slope, the shape of the condyle, the height of the tibial spines. All of these factors play a role in terms of patient outcome. So a lot of things to consider. We can use it for digital planning. We can take some of these new electronic tools to help us plan our surgeries, whether that's an osteotomy for either ACL surgery or even for osteoarthritis. We can take some of our CT scans. We can plan where previous ACL reconstruction tunnels have been. This is an example of a failed ACL. And we can cut away, remove some of the bone, and then plot out exactly where the tunnel is. This is a perfect tunnel. This tunnel here, you can see all the way up there, okay, is way, way away from where it should be, okay, and this one's very close. And with studies such as this work that David Parker's doing as part of our advisory board from Sydney, they can take MRI scans, and we can do exactly the same with an MRI scan. We can work out exactly where the tunnels are, and when we're planning ACL revision, we can use some of that information to determine exactly where we go. And what's really exciting about this is we can take that information, whether it's from our ACL reconstruction, and we can put it into the lab. We can take all of those outcomes that we have in our rehab lab, and we can start correlating some of those really, really interesting outcomes in the lab to what we're doing surgically. And again, this is something that we're going to be working on in this particular space. And so then we're really continuing to focus on a data-driven approach to individualized rehabilitation, with a multidisciplinary team sitting around looking at data and determining what's best for our patient population, when we should be progressing, when do we hold them back. So that's effectively ACL precision surgery. I'm going to take a little breather now because we're going to move on to patient-reported outcomes. I just think this is a lovely video of an ACL injury. Okay, so patient-reported outcomes. If we go back to what I talked about with the stability trial, okay, we showed that we had a significant reduction in ACL failure. But look at our patient-reported outcomes. These are the patient-reported outcomes at 6, 12, and 24 months in the stability trial. And what we found, that there was no clinically relevant difference in patient-reported outcome measures. Yet we saw a 66% reduction in failure rate. Doesn't really quite, why do we see no difference in PROMs when you can see an impact of LET on clinically important outcomes? And that's something that we started to think about as to why are we seeing this. Now, patient-reported outcomes, they've become the foremost primary outcome in so much of what we do. And if we look at surgery versus non-surgery studies, okay, and they really have a massive influence in healthcare decisions and policy. But there's a growing recognition that there are challenges associated with the use of PROMs. This is another study, okay, and if you look at this is a randomized clinical trial from Nick Mutati and the University of Calgary. They compared patella tendon ACL reconstruction to hamstring tendon single bundle versus double bundle. Across the three groups, no difference in patient-reported outcome measures. Okay, fantastic. Look at the failure rates. 16% failure rate in the double bundle, 15% hamstring tendon, 4% with the patella tendon. Okay, these are significant findings. This is an issue if you're sitting down with your patient. Yet if you just focused on the patient-reported outcomes, you would say, no problems. I've already talked about the BEAR trial. BEAR trial is a really interesting study. Amazing research. But they used the non-inferiority framework. This was an FDA study, so they got FDA approval for BEAR based on the results of this study. No difference in subjective IKDC scores. They get their primary endpoint. Patients are now having BEAR all over North America because they've got FDA approval. Yet there's a 14% failure rate in the BEAR group versus 6% in the hamstring tendon autograft ACL reconstruction. I'm not saying BEAR is a bad procedure, but what we need to be very careful is what is important for our individual patient. If you want to get back to playing sport and failure rate is a high priority for you, then probably this is not the best option for you. If you're 40-something who just wants to run in a straight line, but you want surgery, have a BEAR. It's probably going to do very well. So, issues with PROMs: sensitivity to change, structural validity, and response shift. So I'm going to go over these briefly. And this is Hannah Mamura. Hannah was a PhD student of mine. She's now doing her postdoc in North Carolina. She's an absolute superstar. I've already mentioned a number of her studies already. So how do adverse events influence PROMs? Well, we see with stability breakdown of complications. And what we find is that if we actually really focused on those patients that had some sort of complication, their patients were actually, the patient-reported outcomes were sensitive to those changes. But when you look at a large number of patients, thankfully, the majority of our results actually are pretty good. You're only talking about 10% or less that have actually got a bit of a problem. So the bad results are being washed out by the good results. So if you only focus on patient-reported outcomes, you're not really picking up what's going on in terms of the granularity of these problems. Maybe there's an issue with the proms that are being used. So Hannah delved into this. COOS is one of the most commonly used patient-reported outcomes in ACL literature, particularly in many of the registries, and it's a problem. We very rarely see differences in our patient populations when looking at COOS, and probably because it's not designed to look at ACL issues, and it really doesn't have good structural validity. It's very easy. It has substantial ceiling effects. There's questions in there regarding the degree of difficulty of getting on and off a toilet or changing your socks. There's not many of our athletes have a problem with getting on and off a toilet or changing their socks after an ACL injury. Okay, so that's a problem. So we tried to develop then a more an ACL specific COOS score, really focusing on some more of the more challenging aspects of it, reducing the number of questions from 42 down to 12. And we can see that actually it was pretty effective, and also it was validated using the MOON data, and shows that this may be an easier score to be able to be utilized in a younger population. We've also then looked at the knees ACL, and I think you're going to see an awful lot more of this score, because it's a very disease-specific score for ACL that was developed by a Danish group. We did the English translation to North America, and now we're in the process of using a cultural adaptation of the knees ACL for the Middle East. Because there are many aspects, there are many things that patients do here that many patients don't do in other parts of the world. And if we're doing lots of meniscus surgery with our ACLs, so many patients want to be kneeling. It's a problem for them, okay? So we need to, again, be asking them specific questions in regarding their particular problems. And then the next thing I want to talk about is response shift. So what is response shift? Well, it's basically outcome measures are dependent on respondent on perspectives, definitions, and their cognitive appraisal. Okay, they're asked about what's going on in their lives, and are very dependent on their frame of reference. Okay, their experience, and what they're comparing it to. Okay, so what we're presuming when we ask a patient-reported outcome question is that their frame of mind is the same at their pre-injury or at the time of their injury compared to 2 years later, that they're thinking the same way. And of course, that's probably not the case. And so what we're seeing is an element of response shift, and that's really defined as where patients have recalibrated. They've changed what they're doing. They've changed their internal standards, what's important for them, their priorities, and also maybe their perception and their definition of that particular of that construct, what that actually really means to them. Now, why should we care about this? Well, it tends to obscure the measures of improvement. Okay, so we're maybe not picking up some of the improvements that we're having. Okay, and this has been shown in a number of other conditions, and it's amazing if you look at the spinal injury population, many patients with a spinal injury, if you leave it long enough, their quality of life really changes, and their quality of life is still fantastic. How is that? But if you compare it at the time of injury, it's a significant problem. So patients really do change their perspectives over time. The question is, does response shift happen in the ACL population? Well, we looked at our patients. Looked at patients that had an ACL injury. We asked them to fill out some patient-reported outcomes. We asked them to repeat those at 1 year, and then asked them to repeat the questionnaire, thinking back to what they were like at the time prior to their surgery. That's what we call the then test. And then with that, you see whether or not the response shift is happening. So we had a number of patients having ACL reconstruction, and what you can see is you have an unadjusted change. So that's just your standard post-op minus your pre-op change. That's your typical score that you're going to see in most studies. And then an adjusted change is looking at the post-op minus the recalled pre-op. Okay, and so we'll just look at this very briefly. And what you can see is that the adjusted change, so patients that are actually thinking about what they were like prior, they see a much bigger difference. They actually think they were much worse than they were. So here's your type of recalibration. This is your pre-op to post-op, and then a recalled pro-op. So if you have a positive recalibration, the patient's thinking that they were worse than they actually are, and so you see a much bigger change from pre-op to post-op. Some patients actually had a negative recalibration where they thought they were better than they actually were. And if you look at that across the group, you see that about 60% of patients are having this phenomenon of response shift over time, and about 40% of those patients, it's in a positive manner. Okay, so there's something happening, and it's a bit of now. There are a number of coping strategies that we recognize, and Hannah has done a lot of qualitative work on this, but I don't have time to really talk about it. But there's a lot of things that are going on in patients' lives that actually make them change or make them cope with their individual issues. And so, they use a lot of different lifestyle changes. What we found was very interesting is the number of things that happened to them over that time. You see lots stopped sport. Now, we're not going to see that maybe with the elite athlete population, but if you see recreational athletes, many will stop sport, particularly the younger patient population, starting a new job, going to school, doing different things. This was in the middle of the COVID pandemic, so many experienced the death of a loved one. Okay, that may actually just change your perception and what's really important to you immediately, and not really care. Oh, it's just my knee. It's not that important. We even had some patients say that they were glad that they had their ACL injury because of the positive impact that it had on their life. Think about that. It's pretty crazy. So, what did we conclude from this? Well, it was clearly identified in patients 1 year after ACL reconstruction. And it means that we can't be fully confident in interpreting sort of your traditional change scores. Okay, it may just not be a clear representation of what's going on, and it may be underestimating treatment effects, and it may in some way explain why we don't see an awful lot of difference in our patient-reported outcomes when we're looking at different interventions. Now, you're probably sitting there thinking, well, so what? What does this all mean? Well, there are significant research implications. That we know that the traditional scores don't adequately represent what's likely going to be happening. We need to think about how response shift is happening in clinical research and how that could impact us. Maybe we shouldn't be using change scores, but instead using recall scores. It maybe makes us think that the sort of the use of a baseline score isn't actually that critical anymore, and just having a score at the time of your follow-up is just as good. Future studies, we need to really try identify predictors of those changes, but I think this is the key one. We need adequately powered studies, and orthopedics is fraught with underpowered studies. So we really need to be thinking of adequately powered studies, but we also got to think about patient-important event outcomes. For our again, comes back to individualized assessment of our patients. What is important to our patients? And what is an important event outcome? We asked our patients, and if you asked, we have a bit of a disconnect. Some of the surgeons that we asked, well, they're much more thinking about what the long term. We want to prevent osteoarthritis. We want you to be good in your 40s. Most of the young patients, I don't want to have another injury. I want to get back to sport as quickly as possible. Okay. What about the elite athlete? This wasn't in this particular study, but re-injury is going to be key. Performance is not just about getting back to sport. It's about getting back to their pre-injury performance. They may be thinking about their next competition. Contracts are in play. They're probably, I'm saying probably, I'm sure some are thinking about their long-term health, but in the short term, they're probably not that focused on their long-term health. So clinical implications, and this is something that I've got to think about when I'm here, because when I was in Canada, I often felt I was more like a psychologist, but there's a language barrier here for me. And so that's where I really rely on my colleagues, the nursing staff in the clinic, the rehab specialists. We all need to work together to really try and pick up some of these individual concepts or individual issues that are happening and feed it back to one another, because we will miss it. I certainly am not going to be able to pick up some of the cues that I would have been able to pick up with maybe a native English speaking patient. So, take home thoughts. Aspetar precision surgery, well, it's an individualized, multidisciplinary, evidence-based approach to delivering best-in-class care to our patients, and that is what we're striving for at Aspetar. It's a focus on patient-specific treatment plans, individualized rehabilitation, and data-driven management. And I think we'll hopefully see that more and more over the coming years. And the success in research output will be defined by patient-important outcomes. So event outcomes as well as patient-reported outcomes. And it's very important that we define those ahead of time. And with that, I'd like to thank the team, my team, the surgical team. It's the ACL reconstruction is just a part of what we do. But you're going to see Aspetar precision surgery filter through everything that we do within our surgical department. Of course, what I call the Aspetar Galacticos, it's all of you sitting in the room listening online as well. This is truly a team approach. There's a huge number of people that is going to help support what we want to try and achieve. So thank you for all of your help. And then my international colleagues as well. It's a great pleasure to have been working with them. Obviously, I miss them, but thankfully I'm still able to keep going with the work of Stability 2 and all of that ongoing collaborative research.